Anyway, so what I'll do is the next 5 minutes or so is hard to talk about orbital fractures, the 5-day conference. But I'll quickly fast track and then we'll keep some time for discussion towards the end. I apologize for the delay and keeping you all waiting as well. So I'm going to talk a little bit about orbital trauma and reconstruction, drive home certain principles. For those of you who are ophthalmologists, at least you kind of know what we oculoplastic surgeons do. We'll quickly touch a little bit about classification because the only orbital fracture that most ophthalmologists are aware of are orbital blowout fractures. That only actually forms a small proportion of the fractures that we fix. We'll talk about indications for interventions, which for you, general ophthalmologists, when to refer patients, how do we plan our fracture repairs for all the complex fractures, a little bit on approaches, certain touch on implants, and finally complications. And feel free to stop me at any time. If there are patients there, please make sure that you don't take any photographs of patients here. Only conflict that I have is we have a treatise on orbital fractures coming out in the next few weeks to few months, and this will be the most comprehensive from maxillofacial surgeons, plastic surgeons, ENT surgeons, but anchored by an oculoplastic surgeon. So when you talk about orbital reconstruction, there is anatomical reconstruction, which when done well used to results in good functional outcomes. But finally, what is most important, the patient, a traumatized eye, a traumatized patient, traumatized orbit, she will get back into society looking normal and feeling normal. And that's why there's onus upon us to deliver the highest possible outcomes for these patients. There are numerous classifications available, but in the interest of time, we've classified most fractures into simple fractures, in which these are isolated orbital fractures, to complex fractures like these ZMCs, naso-orbital ethmoidal fractures, Lafort fractures, and cranioorbital fractures. And the take-home message for most of you is when you have fractures like these which involve the orbit, you have to be a member of the craniomaxillofacial team. So you have to learn to work with teams. But when you have isolated various forms of orbital fractures, these are the fractures a lot of times you're able to fix things yourself. That's the simple way is it. All this is actually available in the literature. So examples of pure blowout fractures and complex fractures, which tells you that you're actually part of a unit to manage trauma itself. The other important things about definition of management is the way you manage the child versus an adult, the way you manage a bilateral versus a unilateral fracture, whether it's simple or complex fractures, whether the fragments are displaced or undisplaced, whether there's an underlying globe injury and optic neuropathy. All these varies the threshold for intervention. That's why you as an ophthalmologist become the first port of call to tell a maxillofacial surgeon, a facial plastic surgeon, fix this, don't touch the patient, let me fix the globe, then you go fix it, okay? That's where these patient-defining factors kind of comes in as well. Examples of fractures that I'm going to show you, ZMC fractures is the second most common fracture of the face, where the zygoma is shifted. And I have ophthalmologists refer me cases saying, oh, it's a ZMC, but does not involve the orbit. Not true. Zygoma is an inherent part of the orbit. And all zygomatic fractures are orbital fractures, and whether you're involved actively or passively is your oculoplastic surgeon's call. Examples are naso-orbital ethmoidal fractures. There's a telescoping or bursting of the medial part. What is important for us oculoplastic surgeon is you see these silicone stents. A high proportion of NOE fractures involve the nasolacrimal duct system. Hence, again, an ophthalmologist and oculoplastics is involved because doing a DCR for these patients after all this hardware goes in is a nightmare of a procedure itself. And of course, when you're involving cranioorbital or panfacial fractures, you don't even know where the orbit starts and orbit ends. And what to us defines the orbit is the position of the two globes as well. And that's what tells both the craniomaxillofacial surgeons and us that to direct how to fix the roof first, followed by the lateral wall, followed by the floor, followed by the medial wall. That's how you go ahead fix fractures. It's centered around the globes first, okay? Principles of management, life comes first, globe comes second, and then orbital thing. And this is again where you ophthalmologists become part of a team to tell those guys when to do certain things and when not to do certain things. So if you have a whole skull broken from top to bottom, where do you start? We start from the top, fixing all the way to the roof, lateral wall, the zygoma, cheek, midface, and the mandible. And likewise, when you have a fracture all the way from the outside inside, I have oculoplastic surgeons sticking implants inside the orbit with the zygoma not fixed at all. So it's always top to bottom, outside to in, and that's how you fix these fractures itself, okay? So what are the indications of intervention? In the past, especially our non-oculoplastic surgeons, this used to be the indication. Answer is no. Those are not the indications as well. You want to have significant deformity. They have to have functional implications. Aesthetic implications come second or third. And the most important thing is before you touch the patient, make sure you have a direct, honest conversation with the patient so it's an informed consent itself. So significant deformities like these are what needs to be fixed. And if you cannot fix them, at least find a surgeon in your region who can fix it for you as well, okay? So observations, small defects, one-wall deformities, there's no entrapment in a high-risk patient can be observed, but by default, most other patients usually require some form of intervention. When do you intervene? Pediatric, the younger the child, the faster you want to go in. ZMC and NOE fractures, you want to go in within about a week to 10 days, and only the late patients you do residual deformities. I won't bore you with the approaches, but basically we have transcutaneous approaches and transconjunctival approaches. Gone are the days of big incisions around the face. Most patients, by the time they heal through transconjunctival approaches, do not have any visible scars. Quick word about 30 seconds, Dr. Natarajan. Implants, we now use a lot of bioresorbable implants. I heard there's a paper on glaucoma surgery about bioresorbable implants as well. We've been using it for over 10 years in our practice. And these are implants which do a very good job. And by the time the implant, and these are patients for permanent implants, for example, if you look at I think this is a take-home message. If you see this orbit over here, you see where is the fracture. There's no fracture at all. And if I tell you, this was the same patient scan a year and a half ago when we did the orbital fracture repair, stuck a bioresorbable implant has done its job, bone is healed, implant is gone. That's how you avoid complications as well, okay? So I think in the interest of time, I will probably stop right there. There are lots of newer technologies, but orbital fractures are still within the ophthalmologist territory. If you are the ophthalmologist involved in the phase of trauma, be the ophthalmologist who's available to advise a craniomaxillofacial surgeon, do an examination, tell them what to do, what not to do. You're the ophthalmologist who should be involved after the fracture repair is done, make sure they've not done damage and manage the complications. But if you want to go one step further, identify an oculoplastic surgeon who will become an active member of the team. And I thank you very much, and Dr. Natarajan for chairing the session and all the speakers.